let me start the second part of the presentation. Obik has already discussed about the possible etiologies that this patient can present with. I have been assigned with the discussion of basic management of the patient and stabilization of this patient. So, basic management will depend upon the basic pathophysiology that the patient is having, and from the case discussion, from the presentation of the case, we can understand that this patient is having all the features of right ventricular failure with systemic venous congestion leading to congestive hepatopathy, causing ascites, abdominal swelling, bipedal edema, and also there is some form of maybe renal dysfunctions also. So the differentials, as already has been discussed, will be constrictive pericarditis, RCMP, dilated cardiomyopathy with predominant right heart involvement, tricuspid valvular diseases, RV myocardial infarction. Though the presentation is not that chronic or indolent, it will be a more acute presentation, and chronic lung diseases leading to pulmonary arterial hypertension and with progressive right ventricular failure or cor pulmonale. So the initial triage of this patient will require a prompt clinical assessment of the patient as well as assessment of some biochemical markers. So in clinical signs, we have to assess for presence of any hypoxemia, signs of systemic congestion in the form of jugular venous distension, presence of hepatojugular reflux, peripheral edema, pericardial effusion, all these things, ascites and asarca has already been discussed that this patient is having these features. Signs of RV dysfunction has to be clinically assessed, presence of third heart sound, systolic murmur of the tricuspid regurgitation, signs of concomitant left ventricular dysfunction has to be clinically assessed, and also presence of signs of TR, pulsatile liver. Signs of low cardiac output, we have to assess that whether concomitantly the patient is also having low cardiac index, which can be clinically assessed by presence of hypotension, tachycardia, cool extremities, and oliguria. Some important biochemical markers that need to be checked in this patient includes increased lactate levels, the elevated natriuretic peptides like BNP, NT-proBNP, elevated cardiac troponin I or TROP2, which imparts a poor prognostic outcome in this factor, abnormal liver biochemistry in the form of elevated transaminases and bilirubin, altered PTINR, altered renal function, and also we have to assess the D-dimer level. So these are the basic clinical assessment of the signs and symptoms and some basic lab investigation that this patient need to undergo. Followed by that, we have to assess the severity, and this severity assessment is primarily will be done by clinical evaluation, biochemical evaluation that we have already discussed, and also in certain cases, invasive evaluation needs to be done by central venous catheterization or pulmonary artery catheter to invasively assess the pulmonary artery pressure or assess the central venous pressure. Step 2 will be to identify and treat the triggering factors that can lead to this type of congestive symptoms in this patient or worsening of the symptoms like sepsis, new onset arrhythmias, or maybe certain drug withdrawal that patient was taking, and withdrawal of this drug has led to worsening of symptoms. And we have to ensure some cause specific management promptly, particularly in acute cases like right ventricular infarction, where early PCI and opening up of the culprit artery may salvage the damage, and also reperfusion for acute high risk pulmonary embolism. We have to optimize the fluid status that is of utmost importance in a patient who is having suspected systemic congestion. IV diuretics are the mainstay of therapy if there is volume overload, and renal replacement therapy is required in situations which are insufficiently managed with diuretics, like in diuretic resistant cases. Cautious fluid filling to be done if there is low central venous pressure, but we have to be very cautious not to overfill that patient or to avoid any fluid overload. Hemodynamic monitoring and support ideally to be done in ICU or in good HDU setup. The next part of the management will be to maintain arterial pressure, normal arterial pressure or mean arterial pressure in a normal level. It is usually done by norepinephrine or other vasopressors. We will discuss it briefly about the clinical, clues of using these medicines. We have to consider inotropes like levosimendan, dobutamine, or PDE5 inhibitors in certain cases to reduce the RV afterload or the pulmonary artery pressure and to reduce the cardiac filling pressures. And further measures for afterload reduction like inhaled NO or inhaled prostacyclins may be required in certain cases, particularly in patients having high pulmonary arterial pressure. And also we have to consider transferring the patient to a setup where ECMO or mechanical circulatory support may be available in the advanced cases. So acute treatment consists of mainly 4-5 elements. That includes volume optimization that we have already discussed, the restoration of the perfusion pressure by use of vasopressors and inotropes judiciously, improvement of the myocardial contractility, reducing the right ventricular afterload with pharmacotherapy if it is needed in certain conditions and advanced options. Now, common misconceptions regarding volume stabilization in cases of RV failure is that there is a notion that in fact all RV failure maybe can be treated with volume supplementation. But that is not true, because though RV may be physiologically able to accommodate a large variations in preload, and in some patients RV failure are responsive to IV fluids or they are preload dependent, like in RVMI. In majority of the cases of right ventricular failure that we have discussed, it is usually associated with pre-existing RV volume overload, and naturally improper volume loading or overloading has the potential to overdistend the right ventricle and thereby increasing the wall tension, decrease the contractility. It can aggravate the tricuspid regurgitation, increase the ventricular interdependence, thereby reducing the LV filling, reducing the systemic cardiac output, and thereby exacerbating the organ dysfunction. So in all RV dysfunction, volume loading is not the answer. And in patients with RV failure and signs of systemic venous congestion, diuretics are often the first option to optimize this volume status. Invasive hemodynamic monitoring with the presence of a pulmonary artery pressure, protection catheter or pulmonary artery pressure monitoring, or simple use of JVP, central venous pressure, is useful to determine the optimal right atrial pressure needed to maintain the appropriate preload. And decongestion often lead to improvement in the RV decompression and thereby improvement in the LV function also. Now, in volume optimization, we have to keep in mind if there is a massive renal congestion due to this severe RV dysfunction, as a effect of systemic congestion, we have to maintain a sufficient renal perfusion pressure to prevent acute kidney injury. And renal perfusion pressure, it is the subtraction of mean arterial pressure minus the central venous pressure. Naturally, an increase in the central venous pressure will reduce the perfusion pressure, or a significant decline in MAP also will reduce the perfusion pressure. So we have to balance both this mean arterial pressure and the central venous pressure to maintain a sufficient renal perfusion. Adequate diuretics plasma concentration is crucial. We have to give either continuous infusion or at least 3 to 4 doses, bolus doses of diuretics to maintain an adequate level of diuresis, because the sodium excretion with a diuretic usually returns to baseline within 6 to 8 hours. Adequate diuresis and adequate dosing is important. Early evaluation of diuretic response by measuring the urine output or post-diuretic spot urinary sodium content is necessary. And in certain patients who are poorly responsive to diuretics or who have got possible diuretic resistance, in these patients, rapid intensification of loop diuretic dose or starting a sequential nephron blockade with combining diuretics of different mode of action is required. And in certain cases, when the patient is not responding to this diuretic therapy, use of renal replacement or ultrafiltration should be considered. And the poor responsiveness to diuretics may be due to various causes. It can be due to elevated CVP, renal venous congestion, chronic hypotension, low cardiac output, and oliguric acute kidney injury that has to be taken care of before stamping the patient as diuretic resistance. Aldosterone antagonist and in certain cases carbonic anhydrase inhibitors can be beneficial as an add-on to loop diuretics. In absence of elevated filling pressures, cautious volume loading guided by CVP measurement can also be done, and which may be appropriate in certain scenarios. The second point of management is restoration of the perfusion pressure, and for that vasopressors are primarily indicated to restore this arterial pressure. Noradrenaline can restore the systemic hemodynamics without increasing the RV afterload, which is beneficial because there is no effect on pulmonary vascular resistance with noradrenaline. Restoration of coronary perfusion pressure by vasopressors is of utmost importance because the failing RV dealing with volume or pressure overload is particularly susceptible to ischemic injury, and unless we improve the coronary perfusion of right ventricle, it is usually unlikely to improve. Vasopressors restores the cerebral, renal, and hepatosplanchnic perfusion pressures. Targeting a mean arterial PAP of 65 is usually reasonable, and MAP alone should not be used as a surrogate measure of organ perfusion, especially in patients with RV failure and severe tricuspid regurgitation with massively elevated CVP. Because it is not only MAP that we have already discussed, we have to consider the central venous pressure also, because the perfusion pressure will depend upon these two parameters or two variables. Organ-specific perfusion pressure targets have been given almost similar. For kidney, it is slightly higher. We have to achieve at least a perfusion pressure of 65 to maintain adequate renal perfusion. And to improvement of the myocardial contractility is another parameter that we have to considered in these patients. Dobutamine, levosimendan, and phosphodiesterase inhibitor, they improve the myocardial contractility and increase the cardiac output. And they are indicated in patients of severe RV failure causing cardiogenic shock despite treatment with vasopressor. So even when the vasopressors are not giving desirable results or cardiac output is on a downward spiral, we can consider adding these myocardial contractility enhancing agents. It has got a favorable effect on the ventricular arterial coupling by combining the RV inotropy and pulmonary vasodilatation, and it may be preferentially indicated in patients with pulmonary hypertension caused by left heart disease. In certain advanced option like in PH and corpulmonal long-term oxygen therapy and some pulmonary vasodilator uses can be done judiciously. However, the intravenous prostacyclin analogs are very effective in reducing the RV afterload, but it can aggravate the pulmonary hypotension, so it has to be used cautiously. Next is a mechanical circulatory support in these cases. RV assist devices can be considered in advanced RV failure when the patient is not responding despite treatment with vasopressor and inotropes. And reversibility of severe RV failure, as you know, it's more likely to be possible and more rapid than LV failure of similar magnitudes. Temporary RVADs are also available. It can be a very, valuable therapeutic options in many patients. Optimal patient selection, the optimal timing of the implantation to avoid any significant or potentially reversible organ injury. These are two very important parameters for successful implantation or use of an RVAD, and close hemodynamic and lab monitoring and particular monitoring of the liver and kidney function in this patient is extremely important. So these are the RVAD options which are available. There are some direct right ventricular bypass like Impella RP, Tandem RVAD, or the Protect Duo machines, which maintains the circulation or causes RV unloading by this extracorporeal flow. And there are some indirect RV bypass that can be done by the VA ECMO. Now, RV pressure overload, which is an integral part of the RV failure, it is often associated with supraventricular arrhythmia, and we have to take care of these arrhythmias, which can further worsen the RV function and further worsen the systemic congestion. So, atrial fibrillation, atrial flutter, or MATs, which can be associated with RV dysfunction, has to be tackled very rapidly, and unless we control these RV arrhythmias, it can lead to further worsening of the RV failure culminating into cardiogenic shock, because we know that diastolic filling of the failing RV depends on the atrial kick or the atrial contraction and the atrioventricular synchrony. Therefore, rate control alone is generally insufficient, and we have to maintain or try to restore the hemodynamic stability by ensuring reversal to the sinus rhythm. In acute setting, prompt cardioversion may be of usage, and in chronic setting, we can use antiarrhythmic agents. Beta blocker and CCBs may hamper the RV contractility because of the negative inotropy and should be avoided. Amiodarone should be used if antiarrhythmic therapy is required to maintain the sinus rhythm. Class 1C antiarrhythmics as well as sotalol, dronedarone, they should not be used in structural heart disease. And if medical therapy fails, AV synchronous pacing with either the patient's indwelling device or transvenous pacing catheter, it is recommended. Now, constrictive pericarditis already has been discussed. The topic will be discussed by my next speaker. I am not going into details of this, particularly with this patient having a rapid descent of Y wave in JVP or too small sign. The possibility of constrictive pericarditis is higher. So, in nutshell, this is the approach to treatment of RV failure. We have to assess the severity by these clinical parameters, lab values. Then we have to identify and treat the underlying cause. For that, we have got a plethora of investigations which have already been discussed. Optimize the volume status by use of diuretics, cautious use of fluids in certain conditions, restore the perfusion pressure by using vasopressors, improve the myocardial contractility in certain cases by using positive inotropy drugs like levosimendan, dobutamine, and PDE5 inhibitors. And we have to consider advanced options like inhaled nitric oxide or mechanical circulatory support in advanced right ventricular failure, which are not being supported with the conventional therapies. So these, in a nutshell, diagnosing and treating the etiology specific causes, pulmonary embolism, sepsis, all these underlying causes has to be corrected. Correction of the arrhythmia that I have already discussed. We have to try to maintain the AV synchrony and maintain sinus rhythm. Preload optimization if congested, diuretics, if volume depleted, careful fluid administration by CVP monitoring, and maintenance of perfusion by based on mean arterial pressure and cardiac index. We have to monitor this, use vasopressor therapy as and when required, trial of inhaled pulmonary vasodilators in cases of PH, and in refractory shock, we have to use the mechanical circulatory devices, particularly the RVAD devices in advanced cases. Thank you very much for your patient hearing.